I'm Stephen Greer. We're here in Miami to review the recent events in medicine and in surgery, and with us are the faculty of the University of Miami Miller School of Medicine. And over the last week there were a few drug approvals and a couple of drug rejections and some other incidents in the news. So I thought we'd start out first with the new anticoagulant branded as Pradaxa, or generic as dabigatran. Am I pronouncing that correctly? And
yes.
And it got the indication for atrial fibrillation, non-valvular atrial fibrillation anticoagulation. So if we could first begin with you, Dr. Robert Meyerberg. You are a professor, you're a cardiologist, yes, correct?
Professor of Medicine and Physiology in the Division of Cardiovascular Medicine at the University of Miami Miller School of Medicine.
So maybe if you can just briefly review the data that the FDA used, the pivotal trials for the drug. Were they convincing? Were there any controversies?
Sure. So for this specific approval, which, as you mentioned, was for non-valvular atrial fibrillation, the pivotal study was the RELY trial, which was published in the New England Journal of Medicine in late 2009. And basically what that looked at was a very large cohort of patients, 18,000 patients in three groups, one treated with titrated Coumadin, the second treated with a dosing schedule of dabigatran of 110 milligrams twice a day, and the third with the same drug at 150 milligrams twice a day. This was an open-label, non-inferiority trial, so there are some questions about limitations. So what the data showed was that dabigatran at a dose of 150 milligrams twice a day compared to Coumadin gave greater benefit in reducing thromboembolic and stroke risk at an equivalent level of bleeding risk. At 110 milligrams twice a day, it gave an equivalent effect on reducing stroke risk and a lower bleeding risk. Now, the curious thing about the approval is that the FDA went ahead and approved the 150 milligram twice a day formulation, but not the 110 twice a day formulation, but they did allow a 75 milligram tablet to be marketed, which, if you do your math, you can do 1.5 of those twice a day and you get to 110, but that's not what the FDA intended, and the FDA has said that they're going to come out with an explanation of why they did that. The reason it's curious to me is you have some conditions, such as physical instability and so forth, that might put them at a somewhat greater bleeding risk, and I might be happier with 110 twice a day formulation in those patients. The closest I can come to an explanation for what the FDA did has to do with how the drug is excreted. So it is excreted by the kidney, so what they wanted was a 75 out there to use in patients with renal clearances less than 30. But that was not in the trial. So there's some uncertainties about where all this lands. What is not uncertain to me at this point is that the 150 milligram twice a day formulation seems to be better than Coumadin. It's certainly no worse, and it's at an equivalent bleeding risk. Has the advantage that you don't need to get INRs, there's no repeated blood testing. So this gets to the issue of the patient's ability or willingness to tolerate the inconvenience of Coumadin versus a drug that is at worst equivalent to it, and at best better than it.
And this is a good topic. Every doctor has a patient with AFib on Coumadin.
Every doctor has many patients with AFib.
And what are your thoughts on this new drug that's potentially to be safer or less hassle than Coumadin? Would it be worth the much greater cost? How would you factor that in?
I'm glad you brought up cost. That's a big issue. So this, if you go by what has been marketed in Europe and Canada, you're looking at something like $10 a day cost compared to pennies a day for Coumadin. I imagine the company is going to have to respond to that stress, because that's going to play into whether or not the drug will be used or how extensively it will be used. As far as what it's going to do vis-a-vis the Coumadin market, it's hard to predict. I think unquestionably patients who either have had events on Coumadin, cannot take Coumadin for one reason or another, or are so bothered by the multiplicity of blood tests in terms of quality of life, there'll be a quick transition to this drug. For patients who are perfectly content and can be managed with once-a-month INR testing, they may stay on Coumadin for a while. And that's what I'm going to advise my patients. My view on this is whenever a new drug comes out, even a trial as sizable as this, you don't learn everything you're going to learn once it hits the market. So I would like to see what somebody else's patients do on this drug for a while, except in those instances when there is a reasonable indication or approach for transitioning them over, in which case I'll do it right away.
And you had a thought, but let's introduce you. I'm sorry.
Frank Eisman, Chairman of Orthopedic Surgery here at the Miller School of Medicine.
Great.
Just going to make the comment. So that comes out to about $3,600 a year. So I guess you have to figure out how much the blood test costs, everything else. But
the estimates are around $5,000 to $6,000 a year cost, if you use the higher end of the range of projected pricing.
But the other thing that would be nice to see would be to lower the bleeding risk and keep the advantage the same. I mean, I just have patients who have GI bleeds, or they're getting in an accident and end up getting a lot more hemorrhage-type problems than we would want.
I would guess, and this is just a guess, I don't have any inside information on this, I would guess that the FDA is going to go back and relook at that 110 milligram formulation, because there's a good rationale for having that available.
I'm Bill O'Neill. I'm the Dean of Clinical Affairs and an interventional cardiologist. And I think that Bob kind of has summarized the nuisance factor, though, of patients actually taking Coumadin can't be overemphasized. And I think that, if they need to be on Coumadin, they have to be loaded, so it takes 3 or 4 days. So just getting them on and off of the drug is a complete pain. So if you have a patient that, for instance, is on Coumadin and needs a dental procedure or needs some sort of surgery. So I think that factor alone is going to be a huge advantage for this new drug. But
it's a pain, literally. I mean, sticking people, right. Elderly. Yeah. I mean,
but I think we have to kind of have a word of caution, because this is approved for prophylaxis of embolic events in patients who in AFib.
A non-valvular AFib.
Which is kind of a low-risk group of patients. And what I'm concerned about is kind of off-label use. So you have a patient that has a prosthetic mitral valve, to take a very high-risk example, where clotting that valve would be deadly and catastrophic. And if you switch them over, we don't really know yet exactly how well it's going to work in these other kind of high-risk settings. So my suspicion is that doctors will, if their patients can pay for it or their insurance covers it, will probably gradually start switching over. But I don't think it's going to be a sweeping, blockbuster.
You bring up a really important point. So for the patient with the prosthetic valve who needs to be on Coumadin, I have no intention of taking those patients off of it until I see some data that says that this is equivalent, and there aren't any at this point. So we're really talking about not only non-prosthetic valvular, but this is not about people with valvular heart disease either. So the patient with mitral regurgitation, mitral stenosis who has atrial fibrillation is not who we're talking about today. We're talking about the patient with non-valvular atrial fibrillation.
Well, Dr. Mayberg, I'm Samir Schumann, Assistant Professor of Gynecologic Oncology. Do you foresee that this drug would be eventually used for prophylaxis against other thromboembolic events like DVT, or for treatment of PEs?
So it already is being used in Europe for post-operative patients, and there is a study that was reported at around the same time as RELY, looking at patients with venous thromboembolism and showing beneficial effects. So at least equivalent to Coumadin. So I think the answer to that is yes, and I'm much more comfortable jumping to that at this point than I am to a patient with valvular heart disease and atrial fib, and certainly than a patient with prosthetic valves.